Okay, welcome to the Trigeminal Neuralgia webinar. I'm going to try to cover two topics today. The first topic is going to be an overview of the different categories of facial pain. And then I'm going to also interwoven between those topics is talk about some of the treatment options some of the procedures that we can do for those patients that are candidates for these procedures. I'm also going to talk about the probability of success rates between these treatment options for the various types of facial pain. So there are many different kind of classifications for facial pain. The classification that is probably one of the most optimal and one that's kind of most helpful for me is what's called the Birchall classification. And this is the classification that is recommended by the National Facial Pain Association. The reason why I like this classification is it breaks the facial pain types down into 7 different categories, which is useful to help me think about how to manage these specific types of pain. It's also useful in terms of determining the success rates of procedures for the various types of facial pain. The old facial pain classification system was really just only 2 options. You either had number 1, it's trigeminal neuralgia, or number 2, atypical facial pain. And so some of you may have heard that term atypical facial pain, but that was kind of just a bucket of everything that wasn't trigeminal neuralgia. And so there ended up being many different types of people in the atypical facial pain category. So the Birchall classification breaks it down into these 7 types of facial pain. And I want to go through these 7 types in more detail and explain them. So the first category is type 1 trigeminal neuralgia. This is when you hear some physicians say classic trigeminal neuralgia or original trigeminal neuralgia, this is kind of essentially what they're talking about. But the use of the nomenclature type 1 trigeminal neuralgia is much more specific. So a patient with type 1 trigeminal neuralgia has facial pain of spontaneous onset. And what does that mean? That means the pain just came out of the blue. They didn't have a recent surgery or recent head trauma. The pain started, and there's no precipitating event. The patients with type 1 trigeminal neuralgia have episodic pain, and episodic means the pain comes and goes during the day. And I often ask my patients do they have any pain-free periods of the day? If they say, yes, I have no pain for an hour if I sit quietly and my medication's working, that's episodic pain. If they say I have pain 24 hours a day, 7 days a week, that's not episodic pain. And that means they don't have type 1 trigeminal neuralgia. Because in type 1 trigeminal neuralgia, the pain has to come and go. Patient often has pain-free episode between attacks. The pain is classically sharp lancinating pain. Lancinating means electrical shocks. Some people say it's like being stabbed in the cheek with an ice pick. And so it's not an achy pain. If a patient says they have kind of achy pain, then that's not lancinating pain. The main triggers for type 1 trigeminal neuralgia include eating, washing your face, talking, touching your face, having somebody hug you or kiss you, touching the face, wind blowing on the face. And this is also an important factor that they ask patient, because if they have one or more of these triggers, they're much more likely to have type 1 trigeminal neuralgia. If a patient comes in and says, eating doesn't make my pain better or worse, talking, touching my face doesn't make my pain better or worse, that usually means they do not have type 1 trigeminal neuralgia. And the type 1 trigeminal neuralgia, lastly, is caused typically by a blood vessel pushing on the nerve, and we'll talk a little bit more about that. So this is a MRI scan of a patient, and it's called a Fiesta sequence. And on a General Electric scanner. It's called a CISS sequence on a Siemens scanner. But this is the type of MRI scans that we get to study a patient with trigeminal neuralgia. And this is it's important to get an MRI scan for several reasons. The first is that there are some rare situations where a patient could have facial pain from something other than, let's say, a blood vessel or classic trigeminal neuralgia. It could be a tumor. And about 2% of patients with facial pain, it's a tumor that's pushing on the trigeminal nerve. It could be multiple sclerosis. I'll show you a slide of that. It could also be a small stroke. I've had a patient that presented with trigeminal neuralgia after a stroke. And so we get MRI scans in patients to both determine if a blood vessel is touching the nerve, as well as to determine whether or not the patient has any rare situations that could cause trigeminal neuralgia. So how does the trigeminal nerve work when it is injured? So this is a situation where you have a trigeminal nerve. It's this kind of white band here, this ribbon band here, and then there's a blood vessel artery that's shown in black here. And on the when the artery hits the nerve, this is a cross section of the nerve. Here's the nerve is white, and the coating of the nerve is black. These are the Schwann cells are black. So when the artery kind of hits the nerve and puts pressure on the nerve for long periods of time, the Schwann cells, the black coating around the actual nerves themselves, break down. And when they break down, the nerve becomes irritated and can fire on its own, and is thought to cause the pain. So I like to think of the nerve as a copper wire and the black as the rubber coating around the copper wire. So if you think of those old cable wiring wires, and the artery is damaging the rubber coating around the wire and exposing the wiring. So that's how the blood vessel damages the nerve. So in a normal nerve, the nerve signals come down the nerve in the direction of this arrow here. So then the signals come from the face to the brain, and that tells you when you're touching your face or you're eating, you can feel something. Now, when the artery pushes on the nerve and damages the nerve right here in the center, you see that the signals can start right here. So the sensation is not coming from the face, it's coming from the damaged artery and then going toward the brain. And that tricks your brain into thinking that there's pain in the face, even though the damage is being caused by this blood vessel, not the problem with the face itself. So the treatment options for type 1 trigeminal neuralgia are microvascular decompression or radiosurgery, radiofrequency, rhizotomy, and some other treatment options, balloon compression, glycerol injections, and I'll go into these in more detail scattered throughout the talk. So with trigeminal neuralgia, there is again thought to be a blood vessel pushing on the nerve, and this little cartoon picture shows the trigeminal nerve here in yellow, and there's a blood vessel indenting the nerve. Usually with trigeminal neuralgia, the blood vessel is thought to be a branch of what's called the superior cerebellar artery. And this artery usually is located very close to the trigeminal nerve, and in trigeminal neuralgia patients, it's thought to be pushing on the trigeminal nerve. So that's shown here. And then this is the pressure that the nerve sustains. This is a slide from Mayfield Clinic here. Here's another slide showing what happens after you do a microvascular decompression. So during a microvascular decompression, it's a surgical procedure where you move the blood vessel off of the nerve and you put a Teflon pledget in there. And this Teflon pledget looks like a little miniature cotton ball. And what that does is it cushions the nerve from the blood vessel. So the blood vessel is no longer pushing on the nerve directly. This protection of the nerve from the blood vessel allows the nerve to heal. And if you think back a couple of slides, I showed you that picture where the blood vessel was damaging the lining of the nerve. By putting this cotton ball in there, the blood vessel no longer damages the nerve, and in fact, the nerve can then heal. So the nerve regenerates that lining around itself. So that's what we do in a microvascular decompression. So microvascular decompression in type 1 trigeminal neuralgia has a very high success rate. So it's an 85 to 90% long-term success rate. There are some situations where that number may be lower if the artery that that's pushing on the blood, on the nerve is very, very, very large, sometimes that can happen, then that may result in a lower success rate, because a very large artery may put so much pressure that even though you have the little cotton balls placed on the nerve, the artery exerts too much pressure and it can push through the cotton ball. If you have a vein instead of an artery, then the success rates are thought to be a little bit lower as well. So in terms of the microvascular decompression, the main risks of the surgery is there's a 5% chance of some numbness in the face. You need to remember that the trigeminal nerve controls both the feeling in the face as well as the pain. So if the nerve is irritated or impacted by the blood vessel and or the surgery, you can get some facial numbness. So the face is not completely numb. Patients just usually say, I have less sensation on that side of the face. That happens about 5% of patients that undergo the surgery. There's a 2% chance of hearing loss. The hearing nerve is pretty close to the trigeminal nerve and oftentimes can be stretched during the exposure, and so there's a 2% chance of hearing loss. And then about 10 to 15% of patients have no change in their pain as a result of the surgery. So I always counsel patients, you have an 85 to 90% chance of having no pain or significant reduction in pain, but 10 to 15% chance you still have the pain despite the surgery. Okay, so that was type 1 trigeminal neuralgia. So let's talk about type 2 trigeminal neuralgia. This is the second type of the 7 facial pain types that I'm going to talk about today. So if you remember from type 1 trigeminal neuralgia, that is sharp electrical shock-like pain that comes and goes. Type 2 trigeminal neuralgia, the pain tends to be a little bit different in nature. It's aching, it's burning, it tends to be present more often than not. So someone with type 2 trigeminal neuralgia is more likely to say, I have pain most of the day. I don't have that many pain-free episodes. They say the pain is kind of always there as a constant background pain, doesn't necessarily come and go. So it's a more consistent type of pain. Now, patients with type 2 trigeminal neuralgia still can have electrical shocks, but the electrical shocks represent less than 50% of their total pain. So a classic patient with type 2 trigeminal neuralgia might come in and say, 75 to 80% of my pain is chronic background achy burning pain. 25% of my pain is electrical shocks. So that patient, more than 50% is chronic achy pain. That's type 2 trigeminal neuralgia. Now, type 1 trigeminal neuralgia, what we just talked about, that's where more than 50% of the pain is electrical shocks. So if somebody says 90% of my pain is electrical shocks and only 10% is chronic burning pain, that's type 1 trigeminal neuralgia. If the chronic pain is 50% or greater of the total pain that the patient has, that's type 2 trigeminal neuralgia. So type 2 trigeminal neuralgia is thought by myself and others to potentially be an evolution of type 1 trigeminal neuralgia. So type 2 trigeminal neuralgia is a patient that maybe has had trigeminal neuralgia for many years. I've had this pain for 7 to 10 years. When it first started, it was electrical shocks that came and went. And then after 5 years, it changed and gradually became more of a constant achy pain. So that's how type 1 pain can become type 2 pain. Type 2 trigeminal neuralgia also seems to have a higher incidence of tumors as a cause of it than type 1 trigeminal neuralgia. So we talked about the type 1 and type 2 trigeminal neuralgia. Those are the two main types of trigeminal pain that are treated with procedures. I'm going to talk about the other types of facial pain categories and talk about what these might qualify for. So the third category is type 3, and this is trigeminal neuropathic pain. And you notice I'm not saying trigeminal neuralgia here. We're saying neuropathic pain. So this is a type of facial pain that results from an injury itself to the trigeminal nerve. So the nerve is injured, and maybe as it healed, it didn't heal quite correctly, or they healed with some scar tissue, and that's changed the nerve itself and created a situation where the pain just is, the nerve is just not quite normal, and then that results in pain. So situations that can cause type 3 trigeminal neuralgia would be facial trauma, oral surgery, head and neck surgery, that's ENT, ear, nose, and throat surgery, a stroke, skull-based surgery, any type of either surgery, trauma, or injury to the trigeminal nerve can cause this type of pain. So this type of pain is usually described as a unremitting, throbbing, burning pain. This pain is there 24/7. They have no episodes of pain, being pain-free. They don't really respond to the classic medications for trigeminal neuralgia, and so this is a difficult patient to treat because the problem is within the nerve itself. The nerve itself has been damaged. So this is not a patient that is a good patient for, let's say, a microvascular decompression. This is an example of a patient with who sustained an injury. So this is a 71-year-old, and he woke up one morning with some numbness in the face. So that meant some injury to the trigeminal nerve because it carries a sensation of the face. And the numbness resolved over 6 to 9 months, but then was replaced by this trigeminal neuropathic pain. And this, on the MRI scan, you see on this image here an area that's darker gray than the rest of the brain. And on this sequence here, you see the same area. It's lighter, it's whiter than the rest of the brain. So this is the area where the patient had a stroke. And in this area, this is right where the trigeminal nerve comes off of the brainstem to exit the skull. So this stroke just happened to land right on the trigeminal nerve. And as the nerve healed, it didn't heal correctly, and that resulted in the trigeminal pain. So type 4 is called trigeminal deafferentation pain. This is also pain resulting from an injury to the trigeminal nerve, but this injury is thought to be related to a treatment. So this is, whereas type 3 was an accidental injury like a trauma or a stroke or something along the lines that that came out of the blue unexpected. Type 4 is a pain that results from injury to the trigeminal nerve as a result of a prior either procedure of the nerve itself. So if you do a procedure and try to damage the trigeminal nerve to alleviate the pain and it doesn't work and scar tissues form, you can get type 4 trigeminal deafferentation pain. The pain is described as a burning type of pain, itching, crawling. It's kind of there all the time. A component of this pain is called anesthesia dolorosa, and this is a excruciating pain that is also perceived as a numb area of the face. So you have numbness when you touch the face, but there's also pain perception there, which is kind of almost contradictory, that you don't feel the area, but it's causing a lot of pain. And that's type 4 of the trigeminal facial pain. Type 5 pain is trigeminal pain from multiple sclerosis. So how does this work? If you remember a couple of slides ago, I showed you, I'll go back here, I showed you a slide of a stroke, right, where the trigeminal nerve came out. You can also have multiple sclerosis, which can look very similar to this stroke. Multiple sclerosis is a autoimmune attack of the brain tissue by your body, and that can result in injury. If that attack occurs right at where the trigeminal nerve is, then you can get trigeminal neuralgia pain from this multiple sclerosis. So 1% of patients with trigeminal neuralgia have multiple sclerosis as the cause of their pain. 1 to 3% of patients with multiple sclerosis end up having trigeminal neuralgia. So it's not high in either direction, but this is something that you need to think about. The pain can either be episodic or constant. And what causes the pain is your body's own immune system attacks the lining of the trigeminal nerve. And if you remember that original slide I showed you where the blood vessel was pushing on the nerve and damaging the lining of that nerve, this is the same situation where the lining of the nerve is damaged, but instead of a blood vessel, it's damaged by your body's own autoimmune system. So in patients that are younger, multiple sclerosis is a more common finding, and an MRI scan typically would provide evidence of multiple sclerosis. So here's kind of what happens in a trigeminal neuralgia from multiple sclerosis. We have the nerve is this white part in the center here, and the lining of the nerve is the yellow part shown here. During the multiple sclerosis attack, your body's own autoimmune system attacks and damages the yellow lining around the nerve, and it exposes the nerve fiber themselves right there. And that exposure of the nerve fiber irritates the nerve itself and can generate the trigeminal neuralgia pain. Type 6 facial pain is what's called postherpetic neuralgia. This is the same virus that causes chickenpox or zoster. So it's a virus, it's just a herpes virus that likes to live in the nerves themselves. And the virus can travel down the nerves to the face and result in an outbreak of like a chickenpox lesion along the face in the distribution of the trigeminal nerve. And what that does is just having the virus in the nerve causes the paining. It's a burning type of pain. It's usually, unlike most other trigeminal neuralgia, which affects the lower part of the face here, the postherpetic trigeminal neuralgia can affect the upper part of the face on the forehead above the eyebrow. Again, usually associated with kind of outbreak of like chickenpox type of lesions on the skin. This would not be a procedure that you would treat with surgery or anything like that. You would actually treat this with antiviral medications, and that would make the virus run a shorter course. And as the virus dissipates, most of the time, but not always, the facial pain goes away. So this is usually pretty easy to distinguish this type of facial pain because it has the lesions on the face. None of the other types of 7 types of facial pain have something on the skin that you can see. Now, this type of postherpetic trigeminal neuralgia can occur multiple times over a patient's lifetime, and if the virus pops up several times during the patient's lifetime, it usually can pop up if there's some stress on the body. The nerve activates itself and comes down not the nerve, but the virus activates itself and comes down the nerve and manifests itself in the skin. The last type of facial pain is type 7 facial pain. It's face pain of obscure etiology. And this type of facial pain is pretty much everything else that does not fit in the other 6 types of facial pain classification. If a patient ends up in this category of facial pain, it's difficult to treat because we often don't know the exact nature of the problem. These include patients that are where the pain is really severe, it disrupts their life, but when you look at you do the neurologic exam, it seems to be normal. When you get the MRI scan, it seems to be normal. Some of these patients, just from the stress of the pain, develop some psychological issues, anxiety, depression, and which then in turn make the pain and the perception of the pain worse. If you're depressed, pain is known to be elevated in terms of the way a patient reports it. And it's not just trigeminal neuralgia, it's any type of pain. Back pain, orthopedic pain are all scored as being more severe in a patient that's depressed. This type 7 facial pain includes patients that come in with saying they have pain on both sides of their face. So if the patient says, I have pain front of my head, back of my head, left side, right side, is clearly not going to be related to a single blood vessel pushing on one nerve, because one nerve doesn't supply the innervation to all parts of the head. Also, if pain occurs outside of the trigeminal distribution, then patient's head, when color, the trigeminal nerve covers the area of the face that's kind of these shades of pink there. Now, if you notice behind the ear, it's not pink. It's kind of this beige color. that's not innervated by the trigeminal nerve. That's innervated by nerves that come out of the spine here, and we call the cervical nerve roots innervate up here. So if a patient comes in and they says, I have pain right here in the back of my head, behind my ear, that's not trigeminal pain. The trigeminal nerve does not innervate that part of the face. So that would be a situation where we'd say, okay, you have this type 7 face pain. It doesn't match the trigeminal distribution. So I want to talk a little bit about some of the procedures. I talked about the microvascular decompression surgery. That's done commonly for type 1 or type 2 trigeminal neuralgia. So for the first 2 types of facial pain, it's commonly done. I've also done the microvascular decompression for the multiple sclerosis, the type 5 facial pain that we talked about. Sometimes the multiple sclerosis is just enough to push the patient over the edge. They have a blood vessel touching their nerve, and it wasn't enough to cause any problems. But once they had a multiple sclerosis attack, the combination of the multiple sclerosis plus the blood vessel pushing on the nerve is enough to cause them to have trigeminal neuralgia. So if you do a microvascular decompression, those patients, they often can get better. Now, let's say a patient is not a candidate for a microvascular decompression. What are some of the other options that we can try? One option is called a radiofrequency rhizotomy, and this is a situation where we can stick a needle into the nerve, and typically heat is used to damage the nerve. And you're deliberately damaging the nerve in hopes of disrupting the pain fibers with this technique. The advantage of this technique over the microvascular decompression is that it's a more minor procedure. It's kind of done in the operating room, but it doesn't involve opening up the skull. The disadvantage of the radiofrequency rhizotomy is that it achieves its results by damaging the nerve. So you're not doing anything about moving a blood vessel off the nerve. You're not necessarily dealing with the root cause of the problem, but you're damaging the nerve. Now, why is that an issue? 2 issues. If you damage the nerve, and this nerve also controls the sensation or the feeling in the face, you could create numbness in the face. And if you do this radiofrequency rhizotomy, the risk of numbness in the face can be as high as 90%. Because again, you're damaging the same nerve that carries the sensory fibers. The other issue with this technique is that over time, your body doesn't know any better. And so when the nerve is damaged, your body thinks it's supposed to heal. And so by healing, it could reconnect the pain fibers. So a patient undergoes a radiofrequency rhizotomy. There are some that get long-term relief, but I would say the majority of the patients, the pain recurs over time, over the course of several years, as the nerve heals and doesn't know that it's not supposed to heal. So the nerve heals and the pain can come back. This is another picture of how we do this procedure. So again, you stick a needle into the cheek itself, up to the nerve. The nerve has the 3 branches here, and the tip of the needle has a little thermal probe on it, and what that thermal probe does is it damages the nerve by essentially cooking the nerve or frying the nerve at the tip of that metal probe. Another treatment for trigeminal neuralgia is the use of radiation, and machines that commonly do this type of radiation are CyberKnife or Gamma Knife, or a true beam or X knife. There's a bunch of different names. The most common ones are CyberKnife and Gamma Knife by names. And so during this procedure, you are essentially damaging the nerve not with heat, but with radiation. And so this is a picture of what a CyberKnife machine typically looks like. The patient reclines on a table here. This is kind of a semi-sitting, but the table's flat during the treatment. And the CyberKnife directs a focus beam of radiation, like a laser beam or laser pointer beam, to the trigeminal nerve and delivers the radiation to that nerve to damage the nerve itself. This technique also has the same or similar problems as that for the radiofrequency rhizotomy, that heating up of the nerve, because you're damaging the nerve itself to achieve the results that you would want. So that can cause numbness, although the numbness after radiosurgery is not as high as that for the radiofrequency rhizotomy. The radiation numbness rate is about 30 to 50%. But again, the problem with this situation is the nerve can heal over time. And as it heals, that can result in repair of the nerve and their recurrence of the pain. So after the radiation, there's about I would say 50% chance over the first 5 years that the pain can come back. So in terms of results of the radiation, there's two graphs here. The graph on the three bars on the left show the pain relief initially. So like within, let's say, a couple months of the radiation treatment, patients were asked, is your pain better, or is it gone, which is excellent, or is it 50% better, which is moderate, or is it only 25% better? Let's say that's mild. So if you add up these numbers, they actually add up to about 90%. So initially, 90% of patients show some effect of the radiation. Now, over time, if you look out like 4 or 5 years, that's the long-term results here. You kind of drop down to 50 to 60% of patients still have pain relief. So the downside of this treatment, again, over time, is the nerve heals, the pain fibers get reconnected, and the pain can come back. So this is, I think, one of the last slides I'm going to talk about before we go into the question and answer, but this is what a radiation treatment plan looks like. So here's the nerve itself, and we're targeting, here's the nerve right there, that gray line. We're targeting it with radiation, and the radiation damages the nerve, and over the course of a month or two, the damage to the nerve is enough to kind of knock out the pain in about 90% of patients. And then, in about 50% of the patients, the pain is durable and permanent, and another 50% of patients, the pain kind of recurs over the first 5-year period of time. Both the radiofrequency rhizotomy using the needle in the cheek and this radiation treatment can be repeated if the pain comes back. The issue that comes up is that if you do this a second time, the effects tend to last even less than the first time. So if you do a radiation treatment and it lasts 5 years, and you do it again the second time around, may last only 2 years. So that's not to say that some patients can't have permanent pain relief. Many, some of them do. Some of them have pain relief permanently after the first course of radiation. Some of them have permanent pain relief after the second course of radiation. But the general trend is that the pain can recur over time in these patients. So that's kind of all I want to cover in terms of the classifications of facial pain. So I'm going to switch gears a little bit and switch over to a question and answer session. I'm going to just kind of read the questions that are coming in and answer them as best I can. First question was a question from Melissa, who said, you mentioned when discussing microvascular decompression that the chances of success are lower if the compression is caused by a vein instead of artery. Could you explain why that is? So that's a good question. This is something that's been observed for many years by neurosurgeons, and we don't necessarily have a good answer to this question. The thought process is that the artery carries blood under much higher pressure and pulsates over time, and that results in the nerve being damaged, as by that little cartoon I showed with the lining of the nerve being injured. The vein doesn't carry as high pressure, and the vein doesn't pulsate. So with the veins, it's a much lower pressure, lower irritation on the nerve itself. And in that situation, the nerve might not be damaged as much. So when you take care of the blood vessel, in this case the vein, the nerve doesn't have a lot of damage to repair, and therefore, if the damage was causing the pain, then lack of damage to the nerve results in a lower chance of pain relief. The other issue with the veins is they're thin walled, so you don't really separate them from the nerve and put that cotton ball in between the blood vessel and the nerve. With the veins, you often cauterize them. You take a heat and you seal off the vein completely. And in that situation, that's done so that the nerve doesn't, the vein doesn't regenerate. But it is a situation where the results are less. And I wouldn't say it's a lot less. The arteries I quote like 90%. With if it's just a vein, maybe it's like 75%. So it's not dramatically worse, but it does seem to be worse. The next question from Lauren is, what are your thoughts for a patient with type 3 neuropathic pain to have a dorsal root ganglion neurostimulator? Where did that go? And so, the question is, what's my thoughts in that situation, dorsal root stimulator? So that treatment is an option for this type of pain. It says the nerve was severed during oral surgery and a transplant was done, but it's only partially successful. So a neurostimulator is a more novel treatment for face pain. In this situation, you're sticking a electrical probe into the trigeminal nerve, and you're expecting that the stimulation of the nerve will override the pain. Now, what does that mean? I'll give you guys an example, kind of a more kind of day-to-day example of this. If you stuck your hand on a stove and you burned your hand, you obviously would pull your hand away from the stove, but people do one of two things. Let's say I burn my thumb on the stove. They do one of two things. They either shake their hand, vigorously, or they stick, if I burn my thumb, they stick their thumb in their mouth, or they stick the thumb under cold water. And essentially what you're doing is you're stimulating the area of pain, and you're overriding the pain fibers by creating another stimulation. So I burn my thumb, I stick it under the cold faucet in the kitchen. The cold water running over my thumb is a more powerful stimulus than the pain, and I don't perceive the pain as much from the burn. So that's what a neurostimulator is. The other issue with neurostimulators is it's not covered by many insurance companies. So that makes it difficult for us to kind of recommend this on a regular basis. There's not many neurosurgeons that know how to put in neurostimulators. That's the third issue with that. But essentially, it's something that's kind of exhausted some other options. It's not something that is necessarily bad to be considered, but it's certainly something that can be considered. Okay, the next question is a question. I'm going to read the question. My trigeminal neuralgia seems to be type 1. V3 pain's getting worse. At a recent MRI scan, and the MRI shows that no areas on the side of the pain would be a candidate for microvascular decompression. There was an area on the other side, so I guess on the opposite side of the head, that showed a blood vessel, but you don't have pain on the side with the blood vessel. How can you be sure that the MRI results weren't accidentally reversed? Okay, so a couple comments here. First of all is that most patients, if they undergo an MRI scan, have a blood vessel touching the nerve, even without trigeminal neuralgia. So if I had an MRI scan on myself, there's a good chance that the blood vessel would be touching the nerve. So for every 100 patients that have a blood vessel touching a nerve, only one might have trigeminal neuralgia. So we cannot say that just because the blood vessel is touching the nerve, you have trigeminal neuralgia. If you have trigeminal neuralgia, we look for a blood vessel touching the nerve, but the opposite is not true. A blood vessel touching the nerve does not mean you have trigeminal neuralgia. The other comment I want to make about the MRI scans is that you need to make sure that the MRI scan has the correct sequences done to look for a blood vessel along the trigeminal nerve. So earlier in the talk, I talked about doing a Fiesta sequence, if it's a general electric scanner, or a CISS assist sequence if it's a Siemens scanner. And those need to be thin slice sequences to look along the nerve itself. Many kind of standard brain MRI scans don't necessarily include these these particular sequences. And if I see a patient with an MRI scan that has not had, even if the MRI scan was done last week, if it doesn't have these correct sequences, I repeat the MRI scan getting these correct sequences. Because you need to really know what's going on at the level of nerve, and a regular brain MRI scan without these thin slice images of the trigeminal nerve can miss a blood vessel. And the reason why I know that to be the case is it's very common for me to have a patient, I look at the MRI scan and I see one blood vessel touching the trigeminal nerve. I do a microvascular decompression, and when I get in there, I find 3. So that tells me that, the other 2 blood vessels were either too small to be seen on the MRI scan, or the MRI scan didn't have a resolution of this. Also, even before MRI scans became popular, microvascular decompressions were done for trigeminal neuralgia. So, if we back up to early 1980s, you had trigeminal neuralgia. The neurosurgeon, if you had classic type 1 trigeminal neuralgia, we would offer a microvascular decompression to you, even though we didn't have an MRI scan, because we understood the nature of the disease, that it's a high chance of having a blood vessel in the area of the trigeminal nerve. So the next question from John is, what about pulsed radiofrequency ablation? Doesn't damage the nerve? How does it work, and what are the advantages and disadvantages of it? So essentially what the pulsed ablation is, first of all, I should disclaimer, I don't do that procedure. So I'm going to give you a very kind of maybe a limited answer to that question. But essentially what it is, it's rather than using heat to damage the nerve irreversibly, it's more of a series of pulsations of radiofrequency pulsations to kind of, maybe for lack of a better word, kind of massage the nerve or modulate the nerve so that it doesn't transmit the pain. The only people I know that kind of do this type of procedure are functional neurosurgeons that really specialize in kind of chronic pain syndromes. So I do a lot of trigeminal neuralgia surgery, but it tends to be the microvascular decompression and the radiation, and these pulse radio frequencies are not something that I have a lot of experience with. The next question from Joy is, what is the most successful surgery you've seen work for patients with trigeminal neuralgia type 5 and multiple sclerosis combination? Does the MVD only work if the patient has both MS and a compression on the trigeminal nerve? That's a good question. So if I have a patient that has multiple sclerosis and the MRI scan shows a blood vessel on the nerve, I still will offer that patient a microvascular decompression. And the reason for that is the 2-hit theory that I was talking about earlier. If you have multiple sclerosis alone and no blood vessel pushing on the nerve might be strong enough to tolerate that one hit. If you have a blood vessel pushing on the nerve and no multiple sclerosis, maybe the nerve's strong enough and can tolerate that blood vessel laying on it. But if you have both multiple sclerosis and a blood vessel pushing on the nerve, that's 2 hits to the nerve. It's like punching the nerve in the arm and the leg at the same time, and it's not going to be happy. So in those patients, I do offer the microvascular decompression in the hopes that getting the blood vessel off the nerve will make the nerve happy enough that even though the patient has multiple sclerosis, the pain goes away. I've also done the radiosurgery, the CyberKnife radiation treatment in patients with this type of problem as well. Again, the hope is that, in that case, I'm trying to damage the nerve with radiation to override the pain that's coming down. So I have had patients both that have had microvascular decompression and radiation for this multiple sclerosis trigeminal neuralgia combination. And I've had, in both of those situations, I've had patients go on to have pain relief. So it's not that it can't happen. It's just that I think many neurosurgeons, once they hear kind of multiple sclerosis, think you're in this category that's not treatable, and that's not always the case. So the next question from Kathy is, you mentioned the success rate for MVDs was 85 to 90%. Does this number include patients who have had total resolution of their pain and don't require any more medication, or does it still include patients that have significant pain relief but still need medication? So of the 85 to 90% of patients that have pain relief, the vast majority of them have complete pain relief and are able to get off all medications. So let's say for every 100 patients, 90 get a benefit, 10 don't get any pain relief at all. But let's say out of the 90 patients that get a benefit, maybe out of those 90, 75 get complete pain relief and 15% have substantially less pain. So either they're off medications that have a little bit of pain, or their pain is like, dramatically better. Some patients will say it's like 90% better. I still have a little bit, but it's 90% better. So that number does include patients that have complete pain relief, as well as patients that are better but still require some medications. But the majority of those patients have complete pain relief. In that situation, trigeminal neuralgia after microvascular decompression is the type of surgery that when the patients do well, after a couple of follow-up clinic visits with me, then they are discharged from my practice. I don't see them again because they do well. It is by the fact that the majority of these patients don't need to come back and see me in clinic tells me that the pain relief is durable and long-term for the vast majority of those patients. So Mary asked a question, have we tried Botox for type 1 or type 2 trigeminal neuralgia? I've personally not tried Botox for this procedure. So as a neurosurgeon, Botox is not something in our kind of armamentarium that we use. Botox is typically used by neurologists rather than neurosurgeons. There are some neurologists that use Botox for example, for facial spasms, for headaches. It's commonly done now for kind of migraine headaches, tension headaches. So it is being done for those type of neurologic disorders. I don't have any experience in doing them for trigeminal neuralgia, so I can't really kind of comment more on that particular aspect of it. So let's see if there's any other questions that are left. I think I might have covered all the questions that I see. Okay, any other questions that people have?
Dr. Chang, it looks like John still has one question for you, and then
okay, yeah, I see that.
More.
Okay, so the question from John is, okay, how do you go about figuring out the cause or kind of trigeminal neuralgia if it's atypical symptoms? Like I have bilateral symptoms and I also have throat pain, so probably polyneuralgia. Okay, so it's a good question. So a patient can have bilateral symptoms even with a blood vessel on one side. And why is that the case? Because at the level of the brainstem, there's some crosstalk between the right and left side of the body. So if I see a patient and they have trigeminal neuralgia or facial pain symptoms and it's on both sides, I usually try to figure out which side is more severe or which side did the pain start with, and maybe potentially consider offering a patient a treatment for that side. I have had situations where I treated this more severe side and pain on both sides went away. Presumably the crosstalk in the brainstem was the result of that. So, you can offer treatment in patients with bilateral symptoms. The aspect of the throat pain brings up the question of whether or not there is a component of glossopharyngeal neuralgia here. Now, glossopharyngeal neuralgia is a different type of vascular compression pain syndrome, and the glossopharyngeal neuralgia causes pain in the back of the throat, kind of where the tonsils are. It really hurts to eat or swallow. If something goes down, you're chewing and you're getting ready to swallow, that's when it really hurts. And that's called glossopharyngeal neuralgia. And you can have both trigeminal neuralgia and glossopharyngeal neuralgia in the same patient. So it's essentially different blood vessels pushing on different nerves. One, the trigeminal nerve, the second, the glossopharyngeal nerve. So essentially managing those type of problems would be to try to break out the patient's problem into two categories and see if you're going to do a microvascular decompression, then and the pain is on the same side, you can actually look at both the glossopharyngeal nerve and the trigeminal nerve at the same sitting. They're actually pretty close together. They're less than an inch apart. So when you're looking in there, you can often see both of them. And you know, these combination pain syndromes are rare, but not unheard of. So next question from Kathy is, do you have any thoughts of treating type 1 trigeminal neuralgia surgically in a patient with a history of complex regional pain syndrome? So yeah, this is a pretty complex question. So the main issue is going to be in this situation is if the trigeminal pain occurred independently of the complex regional pain syndrome, if it occurred first, or if it, and the complex regional pain syndrome is in a different part of the body, then you know, you could manage the type 1 trigeminal neuralgia, you know, separately as an independent problem, and you could offer them surgery or radiation or any of the treatment options I discussed. So the answer is yes, we would potentially consider this. Now, if the complex regional pain syndrome is involving the face at the distribution of the type 1 trigeminal neuralgia, then that's a different story. Then you know, then you're having kind of overlapping symptoms in the same body distribution, and then it's going to be definitely more difficult to tease that out. So hopefully that can at least partially answers your question, but that's a little bit of a tough situation. The next question is, my husband had an MVD in 2006. His trigeminal neuralgia came back in 2018. Then he had radiation treatment that failed. He just had a balloon compression. Can he get a stimulator or repeat balloon compression again? What is the success rate for balloon rhizotomy? So the balloon compression is very similar to the heating of the nerve. The difference is that you're sticking a deflated balloon up to the trigeminal nerve, and then you're inflating the balloon, and by inflating the balloon, you're squashing the trigeminal nerve. So you're putting pressure on the trigeminal nerve with the balloon, and then that causes the damage to the nerve. So yes, you can do a repeat compression again. If the first balloon compression didn't help, then repeating it, I wouldn't say has more than about a 50% chance of a benefit if you repeat it. So it's not going to be 90%, but there is some potential benefit of repeating a balloon rhizotomy. Can you get a trigeminal nerve stimulator? Yes, you can. We talked about that. It's a procedure where you implant a stimulator. The main drawbacks I've heard with that is it's not commonly done. There's not a lot of data in the literature, and therefore many insurance companies don't seem to be willing to cover it right now. You know, that may change as we go forward, but our experience at Stanford over the last 10 years is that, you know, when we've recommended this to patients, they've only been discouraged to find out that the insurance won't cover it. Again, this is a procedure that's not commonly done with the stimulator, so there's not that many neurosurgeons that actually do it. Okay, I think I covered all the questions that have come in, and we're getting right at 6:30, so I think we're right at our end time. But I want to thank everybody for participating in this webinar. We will have some webinars going forward for this. We're going to try to alternate between in-person meetings and webinar meetings to allow for diversity of patients to be able to hear the topics that we're going to discuss. Thank you again for your attention and time this evening. Take care, everybody. Bye-bye.
Thank you, Dr. Chang.